Bismillahirrahmanirrahim. Assalamu alaikum. Dear colleagues, today marks a turning point in how we manage fatty liver disease, now called MASLD and MASH. DRAP has approved Resmetirom, the first in class thyroid hormone receptor beta agonist, specifically targeting the metabolic and fibrotic components of fatty liver disease. Unlike previous agents that focused narrowly on insulin resistance or weight loss, Resmetirom directly improves liver histology, reducing steatosis, inflammation, and fibrosis. The MAESTRO-NASH trial demonstrated significant improvement in liver histology with minimal side effects. But with every new tool comes the need for cautious optimism and proper understanding. This is the beginning of a new therapeutic chapter, one that requires evidence-based understanding and careful clinical judgment. In this vlog series, we shall look at how to incorporate this therapy wisely into our practice. Let's start this journey with the science behind Resmetirom. Bismillahirrahmanirrahim. Assalamu alaikum. Today we shall discuss a role of Resmetirom for the treatment of MASH with fibrosis. Metabolic dysfunction associated steatotic liver disease, that is the MASLD. It encompasses a spectrum of liver conditions ranging from MAFLD to MASH, fibrosis, cirrhosis, and hepatocellular carcinoma in the presence of metabolic syndrome. It affects approximately 1/3 of the global population. In Western countries, MASLD prevalence ranges from 20 to 30%, while in Asia it varies from 15 to 45%. The prevalence of MASLD is closely associated with the rising rates of obesity, type 2 diabetes, metabolic syndrome, and sedentary lifestyle. Few words about the intrahepatic hypothyroidism in MASLD. Thyroid hormones are important regulators of hepatic lipid homeostasis and whole body energy expenditure. We know that. Recent evidence suggests that euthyroid individuals with metabolic dysfunction associated steatohepatitis develop intrahepatic hypothyroidism that promotes progression of MASH. In euthyroid individuals with MASH, there is decreased conversion of prohormone thyroxine, that is T4, to bioactive triiodothyronine, that is T3. So there is decreased conversion from T4 to T3. And on the other hand, there is increased conversion of T4 to inactive metabolite reverse T3. So two ways. One is decreased conversion of T4 to bioactive T3, and second is increased conversion of T4 into reversed T3. So consequently, reduced levels of T3 results in impaired intrahepatic THR beta, that is thyroid hormone receptor beta signaling, a state of intrahepatic hypothyroidism which promotes progression of MASH. And how it promotes progression of MASH? There is, because of the decreased TRB activity, there is hepatosteatosis. Then there is impaired mitochondrial biogenesis and mitophagy. There is increased reactive oxygen species generation, and there is increased hepatic and circulatory cholesterol levels. So because of these mechanisms, the fatty liver starts developing in the MASLD patients because of the intrahepatic hypothyroidism. Hepatic thyroxine hormone receptor beta activation leads to metabolically beneficial effects in the liver, including mitochondrial fatty acid uptake and beta oxidation, then mitochondrial biogenesis, and third, increasing surface low density lipoprotein, that is LDL receptor density, and lowering of circulatory LDL cholesterol. So if we activate the hepatic THR beta, so this will lead to these four changes or results: mitochondrial fatty acid uptake and beta oxidation, mitochondrial biogenesis, increasing surface LDL receptor density, and lowering of circulatory LDL cholesterol. Resmetirom, it's a liver-specific thyromimetic, and it improves intrahepatic thyroxine hormone receptor beta signaling, and in clinical trials significantly improved liver inflammation, fibrosis, and lipid profile in patients with MASH. Dr. Stephen Harrison, he's the main behind the phase 3 MAESTRO clinical program, which evaluated the resmetirom in fatty liver disease. It has 4 phase 3 clinical trials. The MAESTRO-NASH is a pivotal study for subpart H approval at week 52 and continues for outcomes at month 54. What was the protocol? That in this protocol there were 3 arms: placebo arm, the resmetirom 100 milligram arm, and the resmetirom 80 milligram arm, and patients were randomized to one of these 3. And then at the week 22, the primary endpoints were analyzed, and the month 54, the outcome of the primary endpoints were analyzed. We shall discuss these protocols in the subsequent vlogs, but here I want to give you the concept. The other 2 trials was the MAESTRO-NAFLD 1 and MAESTRO-NAFLD OLE. In the MAESTRO-NAFLD, these were the safety studies, which there were 4. The one arm was placebo, second arm was resmetirom 100 milligram, then it was the resmetirom 80 milligram, then resmetirom open label 100 milligram, and then Resmetirom 80 milligram open label NASH cirrhotic patients. And after 52 weeks, then it was the second component started, that is the MAESTRO-NAFLD OLE with Resmetirom 100 milligram. The 80 was changed into 100 milligram, and the 100 milligram open label was continued as such. And the fourth phase 3 trial is that of the MAESTRO-NASH outcomes, in which there is a one arm is the placebo, and then the Resmetirom 100 milligram and Resmetirom 80 milligram, and randomization of 3:1. So these four trials, that is the phase 3 trials, they has proven the efficacy of Resmetirom in the fatty liver disease. In today's vlog, I shall discuss with you the MAESTRO-NASH study in the treatment of MASH with fibrosis. And this study, they published this study last year on 8th February 2024 in New England Journal of Medicine as a phase 3 randomized controlled trial of Resmetirom in NASH with liver fibrosis. By that time, it was called NASH. Now it is called MASH. And because of this published trial, on March 14, the trial was published on February 8, and the next month, that is the March 14, FDA approved as a first treatment for patients with liver scarring due to fatty liver disease. And this was the press release of the FDA saying that today the US FDA approved the Resmetirom for the treatment of adults with non-cirrhotic, non-alcoholic steatohepatitis. By that time, it was called NASH. Now it is called MASH, with moderate to advanced liver scarring fibrosis, to be used along with diet and exercise. This is important, to be used along with diet and exercise. As said, today I shall discuss with you this trial, and in the coming 3 or 4 vlogs, we shall discuss this drug in more detail. So the study question for this trial was, does the oral thyroid hormone receptor beta, THR beta, selective agonist, that is the Resmetirom, decrease fibrosis and produce resolution of metabolic dysfunction associated steatohepatitis with fibrosis? This was the study question. And this trial was conducted to answer this study question, or to find out what's the answer for this. We know that the pool prevalence of NAFLD is that there 65.33% of the world's population, they suffer from the fatty liver disease. In Europe, Eastern Europe, this is around 80.62%. In East Asia, 59%. Asia Pacific, 53%. South Asia, 60%. Where we are residing, then the Australia, it is again 68%. Africa, 53%. Middle East, 71%. Western Europe, 68%. North America, 68%. And Latin America, 51%. So it's a global problem and affecting more than half of the population. And in some continents, even 2/3 of the population is being affected. Why it is important? Why then we should be discussing about the metabolic dysfunction associated steatotic liver disease? Because it's a journey from healthy liver to MAFLD, where the fat starts accumulating in the liver, to MASH, where the fat accumulation causes inflammation and liver injury, to cirrhosis and hepatocellular carcinoma, where liver cells transforms into cancer cells. So the normal liver, when the fat content is more than 5% of the liver body weight, normally the fat content is less than 5% of the dry weight of the liver. When it is more than that, then this leads to the MAFLD, MASH, and HCC. So we need to cut this series, this progression, because in the coming years, the fatty liver disease is going to be the #1 cause of liver cirrhosis and cancer and as an indication for liver transplant. Study design, it was phase 3, multi-center, double-blind, randomized, placebo-controlled trial of 52 weeks duration. 245 centers in 15 countries conducted this trial between March 2019 to July 2021. 966 patients with metabolic syndrome and biopsy-proven MASH having non-alcoholic fatty liver disease activity score more than 4 or more than 4, and fibrosis stage F1B, F2, and F3 with stable weight were included in this trial. So the number of patients was 966, and the criteria was patients with metabolic syndrome, who was having metabolic syndrome and who was having biopsy-proven MASH, and the score was to be 4 or more than 4, and the fibrosis stage was F1B, F2, and F3 with stable weight. Already I've shared with you, this was the protocol. 3 arms placebo, resmetirom 100 milligram, resmetirom 80 milligram, and at the start liver biopsy was done, MRI, the MRE was done, LDLC and biomarkers were checked, and the fibroscan was done, and then the MRI was checked at week 16, the fibromarkers were checked at week 24, and at the week 52 all these parameters were checked, and then the patients were followed, and at the month 54 again these were checked. Interventions. Participants of the study were randomized on 1:1:1 basis to one of the 3 study arms. There were 3 study arms. The resmetirom 80 milligram, 322 patients were randomized to this. Then resmetirom 100 milligram daily, 323 patients were randomized to this group, and the third group was that of placebo, to which 321 patients were randomized. Stratification for presence of type 2 diabetes mellitus and fibrosis stage F1B, F2, and F3 was done. All participants received nutrition and exercise counseling according to current recommendations. A second liver biopsy was performed at week 52. So primary liver biopsy was done and secondary liver biopsy was done. What about the outcomes and definitions? Dual primary endpoints assessed at week 52, and these were first MASH resolution, that is ballooning score of 0, lobular inflammation score of 0 to 1, and the reduction in NAS by 2 or more than 2 points with no worsening of fibrosis. So the primary endpoint, if the patient has these outcome, that is the 0 score for ballooning, lobular inflammation score 0 to 1, and reduction because 4 or more than 4 NAS score was included. So whether there is 2 or more than 2 NAS score drop with no worsening of fibrosis. And the another primary endpoint was improvement in fibrosis by at least 1 stage with no worsening of NASH associated score activity. And the secondary endpoint was % change in baseline LDL at week 24. So these were the 2 endpoints. Primary were twofold and the secondary endpoint. Results. A total of 11 of 966 patients had a delay in their week 52 biopsy for reasons related to COVID-19 by that time, and they were considered to have missing data completely at random and were removed from the primary biopsy analysis population. Decision consistent with regulatory guidance regarding COVID-19. So that's the reason when you read this trial, they say it was 966 patients included, but then the patients who were at the final conclusion of the secondary biopsy, They were less than that. So the primary biopsy analysis population consisted of then in that condition 316 in the resmetirom 80 milligram, 321 in the resmetirom 100 milligram, and placebo in the arm of placebo 318 patients. What were the results? 955 patients were randomized because the 11 patients they were removed. Mean age was 56.6 years. Mean body mass index or BMI was 35.7. 89% were white and most had metabolic risk factors. Fibrosis was F1B fibrosis 5%, then F2 fibrosis 33%, and F3 fibrosis 60%. So 60% of the patients were having F3 fibrosis, 33% patients were having F2 fibrosis, and the 5% of patients were having F1B fibrosis. So these are the primary endpoints, the NASH resolution. In the placebo, 10% had NASH resolution, while in the resmetirom 80 milligram, that is the 316 patients, 26%, and in the 100 milligram, it was 30%, and it was statistically very, very highly significant. Then the second primary endpoint, that was the more than one stage fibrosis improvement. In the placebo, it was 14%. In the resmetirom 80 milligram, it was 24%, and in the resmetirom 100 milligram, it was 26%. And then the secondary endpoint, that is the LDL cholesterol, in the placebo, no change from the baseline was noted, while in the 80 milligram, 14% drop was found, and in the 100 milligram resmetirom, 16% drop were found. So these results were statistically highly significant, and both primary liver biopsy endpoints and the key secondary endpoint of LDL cholesterol lowering were met in this trial. The tolerability, more than 1%, they were the grade 1, 2, 3, 4, and it was compared the 80 milligram, the 100 milligram, and the placebo, and then the serious, they were compared, and they were comparable, they were not serious, so the safety profile was reported to be comparable with the placebo. The steady discontinuation in the 100 milligram arm were increased relative to placebo only during the first 12 weeks and were similar in all treatment groups for the remaining period of the first 52 weeks. After 52 weeks, placebo discontinuation were higher than drug treatment arms. And most adverse effects discontinuation in 100 milligram were GI related. No increase in the incidence of diarrhea and nausea in resmetirom relative to placebo-treated patients after the first few weeks. Diarrhea lasted on average 2 to 3 weeks, often characterized as loose stools or worsening of underlying diarrhea. And there was no drug-induced liver injury events in this group. So the key findings of this study: MASH resolution with no worsening of fibrosis, the primary endpoint. In resmetirom 80 milligram, it was 25%, in 100 milligram, 30%, and in the placebo was 9.7%. The fibrosis score improvement of more than 1 point with no worsening of the NASH, that was the primary endpoint. Resmetirom 80, it was the 4%, in 100 it was 26%, and in placebo it was 14%, and very, very statistically very highly significant results. Percent change in LDL at week 24 in resmetirom 80, it was the 13.6%, in resmetirom 100 it was the 16.3%, and in the placebo it was 0. So these were the key findings. Adverse events were mild or moderate and more frequent in resmetirom group 80 milligram and 100 milligram versus placebo. Diarrhea was 27% and 33%. versus 56% in the placebo, and was self-limited with time. And nausea was 22% and 18.9% versus 12.5%. And this is the graphical representation of this data. The NASH resolution with no worsening of fibrosis in the placebo 9.7%, in the resmetirom 80 26%, and resmetirom 100 the 30%, and fibrosis improvement by more than one stage with no worsening of NASH in placebo 14%. In the resmetirom 80 milligram, this was the 24%, and the resmetirom 100 milligram, this was 26%. So resmetirom, both 80 milligram and 100 milligram doses, was superior to placebo regarding both histologic primary endpoints, that is improvement in MASLD activity score and fibrosis stage, changes in lipid profiles, liver biochemistries, and non-invasive steatosis and fibrosis assessment all favored resmetirom. So the conclusion is resmetirom, both 80 milligram and 100 milligram doses showed statistically significant efficacy in both MASH resolution and fibrosis improvement. With favorable safety and metabolic benefits, resmetirom is poised to become the first-in-class therapy for MASH with fibrosis. So, how should we apply this to our practice? Identify the subsets of patients most likely to benefit from resmetirom. Follow the clinical practice guidance algorithm to screen patients for advanced fibrosis due to MASH, and counsel patients on lifestyle modifications for healthy weight loss. Consider pharmacologic or surgical therapies for treating obesity and optimize cardiac risk factors. So this is not the drug for each and every patient. This is very important slide, and I'll need your attention over here. That in clinical practice, in everyday clinical practice, either in your OPD or in your clinics or in your ward rounds, first of all, identify patient at risk. And who are those patients who are at risk? Those are the patients, obese ones, patients with type 2 diabetes, patients with fatty liver on ultrasound, are those who are having first degree relative with MASH related liver cirrhosis. So if a patient has any one of these, whether he or she is obese, having type 2 diabetes, fatty liver on ultrasound, or family member suffering from MASH related liver cirrhosis, this is a high risk. And what you do next? In this group, you check the FIB4. This is the simple score which can you check with the help of your smartphone. And according to the FIB4 values, you put the patient into two categories: the green, the yellow, and the red. If the FIB4 value is less than 1.3 up to 1.2, this is the green one. If the value is between 1.3 to 2.67, that is, it becomes doubles, it is in the yellow group. And if it is more than 2.67, this is the red group. So if the patient has got FIB value of less than 1.2, so resmetirom is not indicated. A patient may be having fatty liver, a patient may be obese, a patient may be having type 2 diabetes, a patient may be having the first degree relative with MASH related liver cirrhosis, but if his or her FIB4 is less than 1.3, resmetirom is not indicated. If the FIB4 value is more than 2.67, we checked and it was more than 2.67, then resmetirom is indicated. Patient either obese, having type 2 diabetes, fatty liver on ultrasound, or first degree relative with MASH related liver cirrhosis, and FIB4 more than 2.67, this is the patient where you will prescribe resmetirom. If it's in between, the yellow group, what you do, now you check the fibroscan, you check the transient elastography, and depending upon the result, You either start resmetirom or you wait. If the value is less than 8, the patient was here in the yellow group, you check the transient elastography by FibroScan or shear wave elastography. I am saying the figures of the FibroScan because I have got the FibroScan and I check that. If the value is less than 8, this patient does not need resmetirom right at this time but needs follow-up. But if the value is more than 8, then this is a patient who should be started on resmetirom. Though the fib value was not directly qualifying to resmetirom, it was less than 2.67, but when we checked the FibroScan, the values were more than 8. So this is the way you select your patients for resmetirom. But in the next, I'll be sharing with you that the NASH-related liver cirrhosis, confirmed liver cirrhosis, this drug has not been, the data is not with us. So the indications for resmetirom will be F1B fibrosis, F2 fibrosis, and F3 fibrosis. If the value is more than 12, clinically the patient has got liver cirrhosis, then resmetirom is not indicated in this group. This is a word of caution. So with this, I pay thanks to you. Thank you very much for listening and being with me in this vlog. In the next vlog, we will further explore this resmetirom molecule because I think that now this drug will be marketed with full force because the fatty liver disease is a very common phenomena, and I showed you the data that almost 70 to 80% of population of ours, they are having fatty liver disease. So who are the patients whom you will prescribe this drug, and whom are the patients whom you will not prescribe? So this is very, very important that you should be knowing to use the drug in which patient. It should not be underused and it should not be overused. So be with me in the next vlog on the same topic, and we shall explore the further aspects of the resmetirom. And I'll try that in the coming couple of vlogs. I discuss this molecule with you, the data which is available to us. I'll share with you that data, and the aim of these vlogs is that we should be using resmetirom judiciously to our patients. We should not be making our patients deprived of this molecule if they are needing it, and we should not be overusing this molecule. And the good point is that it is available to our patients on a very affording price as compared to the price which is there in the Europe, which is there in the America. So see you in the next vlog on resmetirom. Till then, take care. Khuda Hafiz.